also don't see any difference between any timing. Your office time is different. At least in my practice, I have not observed anything practice is changing.
No, nothing,
People,
nothing gets
yeah,
affected. It's
nothing.
our own insecurity that makes us
Yeah,
say that.
exactly. Correct,
Otherwise,
agree.
patients adjust to our timings. Earlier, they were grumbling
Exactly.
that we are going to office and we used to like your night timings. I said yes, but now after 30 years, I can decide my timing.
I know it's interesting actually. Yeah. We should know how to live our life. Otherwise we will be continuously doing all the same work, and value of life we have realized during COVID. Hey, where is the Sipla guy? Anyone is here, or we can start 8 o'clock? It is, because I got one session at 9:15.
Yes, yes, sir. I mean there, sir.
Who is
Hello,
it?
sir. Myself. Hello, sir. Myself, Dhananjay Chomkar, sir.
Okay. Just see how many
Just
guys. Just see how
yes,
many
yes,
guys have joined, because you can hear me properly, no?
yes, yes, sir. Just give me, sir, 1 second, sir.
Yeah.
I'm checking our participant are joined or not, and a span of 1 minute, so we'll start our meeting. Okay?
Yeah. Now tell me, this is also for the other people to watch, or is it
Yes,
only
yes.
for? Is only
No, no,
like
sir.
ad for other people
It is
also can watch?
it is only ad board, sir. It is
Oh,
a
it's only like
panel discussion. Yes,
it is
panel
like more
discussion, sir.
of a only for us, only the
Yes, yes.
panelist and the moderator. Yeah, okay.
Hmm.
No, the link is not open for other, isn't it?
Yes, yes. Actually, it will be open, sir. But we kept only this for the at like a regional ad board.
Okay.
Anuj, can you check other doctors already join or not?
Yes, sir, I'm checking, sir.
How many people you called? 10 people.
No, sir. Total 9 people, included you, sir. 8 are
Okay, so
panelists, and
about
you are the
10
moderator.
people. Okay, yeah.
Sir, how are you, sir?
Fine. Things are okay, but now we have to start in time. That's the only thing.
Yes. We'll start in time, sir. Definitely, sir. Sir, what we'll do, sir? We will start our presentation.
Yeah.
So what we'll do, sir? I will give your
Corporate.
introduction. Yes, I will give your introduction, sir, and I will hand over the session over to you.
Yeah.
So after that, sir, you will take the charge. Okay, sir.
Yeah.
Good evening, sir. I'm audible.
Yeah.
So good evening, all doctors. Myself Dhananjay Cholkar. I'm a regional sales manager. Today we have a very eminent speaker, Dr. Sadanand Shetty, sir, with us. Already you know Dr. Sadanand Shetty is one of the topmost KOL in not only in Mumbai but in India. So with the Dr. Sadanand Shetty, we have 8 panelists. They will discuss on bone in heart failure management, that is MRA. From today's discussion, it is basically from gain the insight on MRA placement and utilization heart failure management. Hyperkalemia, it is a really concern in physician practice, and to create the awareness among the physician on MRA. So for that, we need your your valuable feedback for that. So we'll go ahead in a mass area. So for this, sir, we have very eminent panelist like Dr. Naren Rawar from Rawar Clinic, Dr. Rajesh Uchil from Shushira Hospital, Dr. Pradeep Raj Singh Kani from Surana City Hospital, Dr. Hani Saula from Mokad Hospital, Dr. Manohar Rathod from Rathod Hospital, Bandu, Dr. Pinkesh Raj.
There's no voice.
Yeah. Dhananjay, the voice is. I think you are muted. I think.
And 1984 he completed DM from same institute. Doctor having many facilitated awarded and degrees like FACC, PSCI, FACS, FCPS, FICE, FICC, FICP, FGSI, FGSI, and FASC. Also, doctor having fellowship in member of American College of Cardiology, fellow European Society of Cardiology, fellowship in European Association of PCI. Doctor is currently professor and ex-head of Department of Medicine and Cardiology at D.Y. Patil University, Nehru, and also doctor is available at its own clinic, Sion. So now, sir, doctor, over to you. And over session to you, sir.
Yeah. Thank you, Dhananjay, and all my friends. Many I would know by name, few I know very personally. So let us for about 1 hour. Just few minutes. Slide is getting. You can
Yes,
see
yes,
the
uploaded.
slide. It is getting
Yes, sir,
uploaded,
it is,
isn't it?
yes, uploaded.
Yeah.
Yes,
Okay. Yeah. So thanks, Dhananjay. Thanks, Ipla, for calling us together, and it's always a pleasure, privilege to talk. In a forum where so many of our panelists are our close colleagues. Many I know by their names. Many I know them, and few I may not be knowing them. But it's a good platform for us to talk about one drug which is very important in heart failure, and that is the MRA, which is mineralocorticoid receptor antagonist. And this is a so what we will do, I will show these slides and point where we need to have a panelist discussion. We will stop at that stage. Yeah. So let me have the first slide. Of course, this is just a disclaimer where we don't have to say anything because we are not which is the standard of any presentation that to show this particular slide that we have is more of a teaching, more of advice for the advisory and not for the promotional purpose, etc. Now this is a topic, of course, Dhananjay already introduced the topic, and then now we are going to have the session on the drug, and then we will have the interactive session. So essentially, as Dhananjay mentioned, our objective of today's meet or the advisory board is to put the insight or to gain the insights on the MRAs. One, MRA's placement and utilization heart failure management. Second, hyperkalemia, is it really a concern in physicians' practice? And the third is to create awareness among physicians. Now, when you look at the global heart failure, the epidemiology, almost prevalence of heart failure about 26 million worldwide, 1 to 2% of the adult population with heart failure in developed countries, but predominantly in developing countries, and the prevalence increases with the age, rising to more than 10% among people of more than 70 years of age. So essentially, when you talk about the heart failure, like atrial fibrillation, these are the disease of aging. As you grow old, your chance of heart failure, maybe reduced or preserved ejection fraction is going to be there. So also atrial fibrillation. So these are the disease of aging. And when you are old, we also have other comorbidity like maybe development of diabetes, renal disease, etc. Prevalence in India, 1% of total population, or about roughly 8 to 10 million individuals, are suffering with heart failure, and the annual incidence is roughly half of this, that is 0.5 to 1.8 million every year new cases, and mortality is 0.1 to 0.16 million individuals per year. As a matter of fact, heart failure is almost compared to cancer, because in cancer we talk about the 5-year survival. So also in heart failure, when you talk about the 5-year survival after diagnosis, not more than 50% people survive. So it is almost or even worse than malignancy, cancer. But with the advent of a lot of pharmacotherapy, it is possible to delay both the morbidity and the mortality. Now, there is one question for you. What percent of heart failure patients approach you in NYHA stage 2, 3, 4? And how many heart failure patient goes undiagnosed in India at an early stage, and why? And the second one is, what are the diagnostic and prognostic tools used by you for heart failure patients? This part, possibly we will discuss a little later, but, the percentage of patients approaching in various stages differs depending upon at what level of practice, like at a consulting level, or maybe institution, or a heart failure clinic as a tertiary care. And so our, the number of patients of heart failure at various stages depends upon at what place you are practicing. Of course, it is undiagnosed in India quite a bit, at least in the early stage. That is because of, the awareness is not there, and the risk factor control, 2 or 3 important things what you have to see to prevent heart failure: control of hypertension, control of diabetes, control of body weight, sleep apnea, and things like that. Importantly, 2-3 things are: one is the hypertension, second is the diabetes, and the third is part of the weight, obesity, overweight, etc. Diagnostic and prognostic tools, we know in heart failure patient is a standard one. We possibly may skip that because today we are discussing an important part of, the MRAs. Basically, that is the topic, which is to some extent, according to me, is a neglected topic, because, we have little, we take little stepmotherly, approach when you talk about the MRA in heart failure, because we are scared, because the moment the potassium goes more than 5 or the creatinine more than 2.5, we possibly, don't use, or we don't make attempt to use MRA. Remember, MRA is a very useful drug in heart failure. Now, if you see the expert ACC, the expert consensus update of 2021, and for optimization of heart failure, MRA is one of the drugs, but the recommendation is that we have to see that you have to be cautious in using when potassium is more than 5 and renal impairment, which amounts to GFR of less than 30. Creatinine 2.5 in men and more than 2 in women is a cutoff for using that. But currently we have some drugs which, removes the potassium, like, potassium, the ionic exchange, like drug like Petamar, which we'll discuss later. If it comes to even in this situation, we can use in combination MRA with the drugs which will reduce the potassium level, and that is a Petamar. It is one of the drugs which is available abroad, which has not yet come to our country. Are these parameters, potassium, creatinine, eGFR, tested before and after initiating MRA, and how long? This is an important question we must answer. Maybe during our interactive session, we'll discuss on this subject, but it is important, at least the baseline, the renal function, at least by doing creatinine, and then calculating the eGFR, and then the potassium level is important. In fact, whenever we are using RASI, that is the ACE inhibitor, ARB or ARNI, or when you are using MRA, we have to be, very cautious that, the level of potassium baseline and the creatinine baseline, is measured. Because if the creatinine jumps more than 25% of the baseline, then, we are cautious in increasing the dose. As a matter of fact, we may reduce the dosage. Now, let us look at the ESC 2021 heart failure guideline. If you look at heart failure with reduced ejection fraction, what we call as a HFrEF, and here it is a class 1 indication of using MRA to both reduce the hospitalization and the death. So both morbidity and mortality, class 1 in a reduced ejection fraction. Whereas in a mid-range ejection fraction, it may be considered to reduce both hospitalization and the death is a class 2B indication. Whereas in case of heart failure with the preserved, MRAs are still not established. Though, SGLT2 like empagliflozin, dapagliflozin has been shown, whereas the MRA earlier, TopCat study, etc., has not shown great, the role for using of MRA in heart failure with the preserved ejection fraction. So here it is not included. So heart failure with a reduced ejection fraction, mid-range ejection fraction, heart failure with the preserved ejection fraction, where discussion of using MRA doesn't come. Now, when you look at the overview of management of heart failure, importantly, as shown here, 4 drugs, these are the 4 pillars of heart failure therapy in 2022. What are they? RASI, that means ACE inhibitor ARNI, beta blocker, MRA, and SGLT2. And to me, I don't at all talk about ACE or ARB. I always talk about the ARNI, beta blocker, MRA, and SGLT2. Among the SGLT2, both EMPA and DAPA. Now, to reduce the failure hospitalization mortality for a selected patients, when you got a volume overload, you use diuretics. If you got sinus rhythm with the LBBB, we may use CRT. If it is an ischemic etiology, maybe we'll have to use ICD, that is to suppress the VT. If there is atrial fibrillation, we have to use anticoagulation as a SPAP. There's a stroke prevention. Atrial fibrillation also, we can use digoxin and pulmonary vein isolation. Aortic stenosis, either surgical replacement or TAVR. There is a transaortic valvular implantation. If it's a mitral regurgitation, TE, mitral repair, and if the heart rate is more than 70 ivobradine, if patient has got sinus rate with the LVBB, again, between 130, 140 millisecond, CRTP, that is a preventive, or D with the ICD. If it is ischemic etiology, ICD is required. If there is a severe coronary disease, bypass surgery, iron deficiency, ferric maltose, carboxymaltose, and ARNI for people when they cannot tolerate ACE ARNI intolerant patients, we can use ARBs, that is the angiotensin receptor blocker, and black rays, hydralazine, and isosorbide dinitrate combo therapy. This also is good. And for selected patient, advanced heart failure, the heart transplant, the MCA, that is your mechanical devices. Then comes the long-term, the mechanical, the devices basically as a destination therapy. And to reduce the hospitalization and improve quality of life for all patients, rehabilitation, exercise, and the professional disease management, something like multi-profession, that means heart failure dedicated clinic. So this gives you overview of how to manage a heart failure patient with a reduced ejection fraction. In what percent of patients use MRA for heart failure management? It is almost like today we have to try to use this drug like 4 drugs as far as possible. We must try to use. So we have to use quite significant number of patients. When do you consider starting MRA in patients with heart failure along with the ACE inhibitor, ARB, and beta blocker? That again we will discuss during our question answer sessions. Now, one important thing, when you are using ACE inhibitor, you get aldosterone escape. What happens is that the following an acute fall in aldosterone in response to administration of an ACE, the level of aldosterone rises again. In fact, it returns to the baseline, and this is called the aldosterone escape. And because of this particular phenomenon, after some duration of therapy with ACE inhibitor, so also with ARB, then it comes the angiotensin escape. Both these phenomena ultimately results in increasing aldosterone after a few months of therapy, and this ultimately gives rise to resistance to both ACE inhibitor and ARB. And that is where we have to take care of that. That means you have to block the aldosterone, and that is the role where MRA is very, very important. And that is why we are using multiple drugs in heart failure to prevent the aldosterone or angiotensin escape. Now, improvement, when you compare this spironolactone and eplerenone, we have got 2 drugs available which are MRAs. If you see between spironolactone and eplerenone, now improvement in systolic function is significantly more in eplerenone group. And that is what this particular study has shown, that eplerenone is superior to aldosterone blocker in the systolic function improvement. Therefore, we have to probably prefer. But only point is the cost effectiveness, aldosterone blocker, the eplerenone and spironolactone, the cost almost 15 to 20 times eplerenone over spironolactone. So that is the only issue. Otherwise, probably eplerenone is superior as for the improvement of the LV systolic function is concerned. Of course, spironolactone, eplerenone, hyperkalemia management, we have to be careful. Like if it is more than 6, we have to stop it. If it is less than 40, we have to increase the dose. And between this dose, we have to titrate. whether it's okay to give 12.5 or whether I have to give 25, whether I have to give to 50 milligram, etc. So generally dose is 25 to 50. In some patients to start, we start with small dose, 12.5. And that is what we have to remember. All depends upon the basal renal function and the potassium. What is the preferred dose? How is the dose titration carried out in our practice? It all depends upon what is the the danger of getting sort of hyperkalemia. The prevalence of hyperkalemia is almost 1 in 10. That means 9.3%, out of which 54% was truly related to MRA. This is what the prevalence of hyperkalemia and heart failure. Out of that, nearly half is due to MRA. Therefore, we are always cautious of using this drug. At least in the beginning, we use a small dose, like a 12.5. If you see all these post-MI infarction study, the FEC's reminder study, total post-myocardial infarction, heart failure, RALS, emphasis, TopCat, in all those particular the studies, all have shown that hyperkalemia is a reality. What percentage of patients on MRA develop hyperkalemia, and they require discontinued treatment? And as I mentioned in the previous slide, when it goes beyond 5.86, we have to be really stopping the therapy, at least temporarily, and then start finding out the cause, and then maybe restart with a small dose, gradually build up. If yes, in how many percent of patients, how are these patients managed? That again we'll discuss during the interactive sessions. And so timing of epinephrine initiation outcome in patient heart failure, what is after the MI is the efficacy study, that even within 3 to 7 days after the MI, we can use the aldosterone blocker. There's the epinephrine, and this particular study gives us that particular the advantage of using epinephrine in patient or post MI. Within 3 to 5 days, you see the left ventricular systolic, the diameter, and you see, over 7 days, rather the follow-up, when you use epinephrine earlier as against epinephrine later, using earlier, because they all help in remodeling of the ventricle, etc. Because they are like, neurohormonal blockers. So it helps in shaping the left ventricular size, improving the left ventricular function. In clinical practice, how earlier MRAs are initiated for management of heart failure patients? Again, very difficult to answer actually, because all depends upon the basic illness and the comorbidity, like whether patient got CKD along with the reduced ejection fraction heart failure, or whether this patient has got hyperkalemia due to the other problem, etc. So we have to see all these factors. Now let us see what is the management of patient heart failure with a reduced ejection fraction standard drug, ARNI today. No more ACE or angiotensin blocker. Remember that. ARNI is a drug of choice among the RASI in heart failure, stable or unstable. Remember that. No more we must use ACE inhibitor ARB unless cost is a really issue. But I personally feel cost effective because the number of admission, hospitalization, quality of life is, you have to believe, and once you start using it, you will believe that ARNI is a real game changer. And according to me, one of the real miracle molecule in pharmacotherapy of heart disease is ARNI, according to me, what we have found last 30-35 years. Of course, beta blocker, carvedilol, metoprolol succinate or bisoprolol, MRA, aldosterone blocker, spironolactone, all epinephrine, and today necessarily dapagliflozin or empagliflozin. And this is an important thing what we have learned today. These are the 4 pillars of heart failure therapy today: ARNI, beta blocker, MRA, and SGLT2 inhibitor. Of course, when you got a fluid retention, diuretic. If you got ejection fraction less than 35% and QRS less than 130, if your patient got an infarct, then ICD is a class 1. A non-ischemic also can offer ICD with a class 2 indication. When LVF is EF is more than 35% or device therapy not indicated or inappropriate, then if symptoms persist, consider therapy with a class 2 recommendation, whatever class 2 recommendation drugs. And if it is a sinus rhythm, left ventricular ejection fraction less than 35, QRS is broad, then we have a CRT, that's a cardiac resynchronous therapy, either single, that's called P, D with the ICD. There's a combo device, both cardiac synchronization therapy with the combo device defibrillator. At what stage of heart failure, diabetes and MRA both are needed. That again we will discuss during our, like all these questions I put, I will ask, the panelists, and what is the preferred choice of therapy, eplerenone torsemide, spironolactone, torsemide. Generally, our therapy is a combination therapy. Spironolactone torsemide is a common, as I mentioned, because the effectively ischemic heart disease patient with heart failure, I prefer eplerenone, and because the improvement of the LV function is better with eplerenone, and whatever for ischemic heart patient with heart failure, eplerenone scores over spironolactone. And of course, when spironolactone cannot be given due to gynecomastia, painful, withdrawal bleeding, young female, then we have to give eplerenone, which doesn't have these particular side effects. So now let us come to that, any other indication apart from heart failure, we will discuss that. And what scientific initiative would you suggest to CIPLA for increasing among user, among the CPs? There's a consulting physicians in here. With this now I will close my talk, and we have next about 30 minutes, and I would ask each one of you to give your opinion, like what I talked, what I gave the talk, and what you think, is it relevant, or how often you are using MRAs in practice, etc. Rajesh, you want to start, or?
I'll start. I would like to start. Yeah. So, good evening, all the panel members and Professor Dr. Sadanand Shetty. My greetings to all of you. See, the thing is that these days, from the last 4 to 5 years, I have been seeing that a lot of MRAs are being used now for various indications, predominantly with reduced ejection fraction. And the only worry is that of hyperkalemia, and if there is gynecomastia, which is a very common thing seen by physicians. I think this eplerenone is now a new drug which we are using, except the cost factor, otherwise it is good. And combined with, you can combine it with torsemide, you can combine it with furosemide, along with spironolactone, or torsemide with eplerenone. Both these combinations are available, and we are using it now quite frequently. Besides that, there are other indications also, which probably we'll be discussing later. But reduced ejection fraction, this is the drug of choice. And these days, after we have started doing BNP levels, pro-BNP levels, and 2D echo has now become routinely in every center, it's available freely. So we really are able to assess the ejection fraction and take adequate response to that based on our assessment of the patient, and whether the EF is less than 35 or more than 35, or even as low as 15%, what we see. Dr. Shetty, any other questions?
I think it's the right statement what you mentioned, Rajesh, and it's a very apt and very appropriate comments, and I totally agree with you. Only other indication for aldosterone blocker is for resistant hypertension. As a matter of fact, we don't label hypertension as a resistant till we use a small dose of aldosterone blocker, because in the earlier time, we were, this concept was not there. I think, but last 4 or 5 years in the ESC, in one of our meeting when I was also there in Europe, one of the places, I don't remember where exactly. So they recommend, small dose of aldosterone blocker as the step 4 drug. Like, after starting, maybe CCB, maybe starting, ACE block, rather ACE inhibitor, ARB, or a small dose of, diuretic. If the blood pressure doesn't come under control, use a small dose of, the aldosterone blocker, and then, you add other drug. And generally, it is said because many patients of hypertension have a relative hyperaldosteronism. It's not exactly like a primary hyperaldosteronism. It's not like a Conn syndrome. But somehow the other reason their aldosterone level is like hyper, slight hyperaldosteronism, and therefore to blunt that, we have to use this dose. We have used 12.5, 25, and I can tell you the effect is very, very dramatic in it. So basically, after 2 or 3 drug combinations, particularly RAS blocker, CCB, diuretic, which is in our situation chlorthalidone or indapamide, we are practically not using hydrochlorothiazide now, and we should not be using also. And then add on to MRA, either eplerenone or spironolactone, depends on the cost factor. And then, consider if it is still resistant, the blood pressure not coming under control, that this is a resistant hypertension. Also, of course, hypertension, whether patient is taking the medication adherence, that also important. This is very important. Like in, the UK and all, when Brian William talks in UK NICE guideline, he says the incidence of resistant hypertension has gone down so much now, But the patient, in spite of using MRA and all these triple drugs, if the blood pressure not under control, they do the urinary level of all these drugs just to see whether patient is taking the drug or not. In fact, we also must consider in our country, when you have a difficult to control blood pressure, patient is not taking medicine or not, to find out, the only way is to see the urinary level of these drugs. But so MRA today in our situation, essentially for heart failure with a reduced ejection fraction, also to some extent preserved ejection fraction also. TopCat study is not very, positive like FREP studies, but, aldosterone blocker do have, some ventricular fibrosis, remodeling effect. It can shrink the left ventricular size. So heart failure with the preserved EF, it is not a contraindication, I would say. Benefit may not be as much as SGLT2. And third, in a resistant hypertension, and of course, primary aldosteronism like Conn syndrome, these are the things. But essentially, the majority of the indication is heart failure with a reduced ejection fraction, and then the resistant hypertension. You want to give anything, Honey? Anything, any your comment?
So I would like to say, sir, that eplerenone or basically any this MRA which we are using, they have changed the morbidity and the mortality of this heart failure patients. Army with this SGLT2 inhibitors, along with this. Only thing that I feel is that we should know when to stop and when to not start. If we are clear about that, we can clearly and very nicely use this drug. Especially in the elderly, we have to be more careful, and patients who have borderline kidney function, we have to be more than careful. Otherwise, they are doomed. So only thing is that I think we should start this drug in those patients who are compliant, who are going to do a regular follow-up, who will do the blood test when you tell them to do the blood test. Then this will really prove as a tool when we go ahead with this particular therapy. And I just like your slide where, you have clearly said, more than 4 titrate, up titrate, more than stop. So that is something which we should follow very religiously, so we will not land up with any problems for adverse effects.
I think absolutely very true actually. To Rajesh, if you're there, what Ani mentioned is very true. Only thing is, when you are using this MRA with ARNI, relatively hyperkalemia is not as much as you are using MRA with ACE or ARB. Remember that, because that ARNI, that NI, there's a natriuretic inhibitor peptide that, that drug, like what we are using, like a valsartan and the combination of this, the ARNI. Sacubitril. And sacubitril to some extent, being a NI, so it, helps in excreting the potassium in the urine. So basically, ARNI and MRA is the ideal combination when you're using MRA, It is certainly not with ACE. See, the problem, as Ani rightly mentioned, in heart failure therapy, two important things is, everywhere GFR comes in the way, Like a 30 is the cutoff of GFR for using MRA, using RASI, using SGLT2, every drug, if you see that. So as a rule of thumb, I always say 30 is the cutoff, Even anti-diabetic, metformin 30 is the cutoff. So this is just something like, which you can easily remember in our, day-to-day practice. And therefore, we have a problem. RASI will increase the potassium, ARNI will increase the potassium. But you want to make use of MRA because, MRA is very important actually. As Ani rightly mentioned, if you see the mortality benefit, if you compare with the, like a beta blocker, ACE inhibitor, ARB, almost, 35% of the MRAs. So it is a very good drug, and that is why the researchers now also feel, of course, when that will come to India, I'm not sure. Abroad is already available. It's a costly therapy called Veltesa, which is, your petiomar. That is a potassium reducing, like how we are using K-bind for, in a patient of hyperkalemia, CKD. So they are using with MRA that drug. That drug means like they're like a polymer. They are like ionic polymer powder, and you have to use just like a K-bind. 6.2 no, 8.4 gram, that particular sachet, and then you have to increase, etc. And this is, almost like a routine in a select patient in this setting, because you want to take advantage of this drug for heart failure, morbidity, and mortality benefit. It is very easy to say don't use, but then what to use in heart failure, bad cases, with a rising creatinine or potassium is going up. So use this potassium, so-called like a binder, that like, what is called as a patioma. Of course, it has some GI side effect and all, some constipation, diarrhea, vomiting and all. Otherwise, only thing is the cost is a major issue, but it is available abroad, Veltasa. Few of our colleagues have used even in India, imported drug, but we are not yet, used. But possibly, in course of time, with our pharma industry being so strong, we will get soon and at a very cheaper rate. Like if you see now omega fatty acid, eicosapentael ether now available, like I don't know whether you are aware of it, one drug called Cosatil, which is 20 times less costly than Vasepa. I don't know whether you use omega-3 fatty acid after the reduced trial, it is as a mortality benefit and all. Now we know the 1 gram of Cosatil is available, which comes to almost 20 times less costly than the international brand. So I am pretty sure soon we will get this Veltasa, which is the potassium binding polymer, which is called patioma, patioma. So why all this research is going on and people are going in this direction? Because they want to make use of MRA. It is very easy for us to say rising potassium, rising creatinine is a contraindication, but to take the benefit of this drug. And that is why, heart failure researcher now said 4 drugs. That means, ARNI, beta blocker, SGLT2, MRA are the more, like a cornerstones of today's, 4 pillars of heart failure therapy. Problem is the side effect. Of course, we have to manage that till we get patiomar or a potassium binders. We have to use little strategically. As Ani rightly said, potassium baseline you have to do. You have to do the baseline renal creatine pumps, etc. And then maybe regularly in the initial period, maybe couple of weeks, once in couple of weeks, maybe once in 4 weeks, 6 weeks, depending on the situation. And then, of course, frail, elderly people, you have to be more cautious. Comorbidity is important, etc., etc. So, but it is an important molecule, and we have to make, maximum attempt to use it rather than saying, I won't use it like that. Okay. Vaibhav, you have any comment?
Yes, we are using it.
Yeah.
Yes, it's very useful, and the creatinine and the potassium has to be monitored. That is true. Yeah. Otherwise, it's a really useful molecule, both eplerenone and spironolactone, sir.
Yeah, I agree. The only thing is, eplerenone we really resolve because the cost issue, But young people, we have, because, some people painful gynecomastia is quite a bit, Some of the gynecomastia I've seen, it is really hard to believe it can give, Withdrawal bleeding in young female, working female and all is a real issue. Painful gynecomastia is a real issue in some patients where we have to really change out eplerenone. But good thing again in the Indian pharma that good combo therapy is available. Like one of my most common, like a torsemide with your spironolactone 25 milligram, 10 plus 25, or maybe 10 plus 50. So also eplerenone, 10 plus 25, 10 plus 50, like that. So we are fortunate that our Indian farmers are giving us various combo much earlier than the Western people. That's the thing. Anuj, you want to say anything? One by one we can start talking. Or Sajjan Mehta, Pinkesh, you have anything? Whoever has not given a remark, you can give this. Yeah, Pinkesh, you want to say anything?
Yes, sir. Sir, except the cost, the drug is fabulous, sir. So we have used in our practice and it has given awesome results, sir.
Yeah.
So if the pharma companies come with a lower cost, I guess maximum people will use this combination, and it basically also lowers the hospitalization of the heart failure patients. So that wise, I think it is a cost-effective drug, but for the common man, they do not understand the long-term benefit of this.
Yeah,
so
I agree.
More awareness in the patients is must, and lowering the cost as much as possible by the pharma companies would be better, sir. Thank you, sir.
I totally agree with you, Pinkesh, because basically, here, to give the benefit of this drug, in such situation, even spironolactone also is okay, you know, because torsemide spironolactone combo is reasonably, you know, cheap. And I think, you know, every time talking about eplenon in such patient, as you said, really poor. And, you know, this is one of the drug in heart failure. We have got a multiple drug to use in heart failure, plus the patient has got diabetes, that drugs, you know, like that. And the patient has undergone, you know, PCI surgery, those drugs. So we have to look at the patient's, you know, overall cost, and ultimately they should adhere. These drugs are for long-term morbidity and mortality. Benefit will occur when patient continues to take, you know. So this we have to emphasize. And what you rightly, you know, brought out, that re-hospitalization is very, very important, you know. So we need to have little, you know, time for heart failure patient. As you said, cost is cost part we have to discuss, and the cost is cost effective, because if a re-hospitalization, the hospitalization costs so much, you know, then the quality of life and the entire family suffers, you know. Therefore, heart failure is a real nuisance, you know. I never like heart failure because the entire family suffers, you know, like young children, their education, every time hospitalization in ICU and things, and another few lakhs of rupees. So they really get into, you know, bankrupt and all, you know, in average family I'm seeing. So we have to put to them little, you know, extra comment about why these particular drugs are important. Therefore, you know, even use of ARNI also, I'm hard pressing with the patient, because it is a drug which will prevent hospitalization, prolong life, your the quality of life, you know, etc. You know? So that point what you brought out is re-hospitalization part. MRA has got a significant, you know, a role along with the ARNI in a re-hospital. That's important. I think we have not discussed that question. That part is good. You have brought out that point in here. Anyone else, Anuj or Sajjan Mehta, anyone, or Pradeep Rai Singhan is there, or Dhananjay, anyone is Naren is there, or who else is there?
Yes, sir.
Okay, so basically, what Dhananjay, the whatever you have put the questions in the ad board, most of the things you have answered that, you know, like how to use, how to optimize, how to prevent re-hospitalization, what are the indication of the MRAs, when to use spironolactone and when to use eplenon, and how to, you know, manage hyperkalemia with MRAs, like, you know, taking care of, you know, the other drugs which may come in, you know, in our practice definitely in course of time, because I'm pretty sure Petiumor will be available in our country soon. So we know that how to optimize the drug. Okay. Anything else you want to ask? Anything, or you want to ask the panelist?
One question,
No, sir,
Dr.
actually,
Shetty,
thank you.
from my side.
Yeah, Rajesh. Yeah.
How do you manage patients of heart failure with a EGFR less than 30?
No, there again, you know, see, basically, as you said, Rajesh, these are the, you know, routine standard situation is more than 30 is, you know, you can use these drugs. But now, you know, the off-label like that, you know, SGLT2, even, you know, used even in 20 also.
Correct.
But the point is that initial period, you know, 4 to 6 weeks, you have to be little at caution in here. Basically, all these drugs, in the beginning, they reduce the EGFR. And once, you know, after 4 weeks, 6 weeks, 8 weeks, they increase the GFR, because, you know, they totally change the, you know, the renal parameters, etc. So that initial period you have to be cautious. Why the GFR of 30 has come as a sort of, you know, standard? Because, like, if you use very, you know, loosely without care, and if GFR goes down during that time, AKI, acute on a chronic renal failure, you know, and then, you know, the heart failure, all these settings may deteriorate the patient. So we have to be using, for example, in such situation, even 12.5 spironolactone. ARNI, you may start with, you know, 50 milligram, 25. Even we have made even sometime quarter, you know, by time, you know. Remember, all these drugs, what you are using in heart failure, they are more for the prevention of a recurrent hospitalization and death. You know. What current researchers are saying in heart failure, try to make these 4 drugs as early as possible in the armamentarium. And they given us about 4 weeks time. Their main thing is that in 4 weeks time, try to build up these 4 drugs. But that is, they are talking, but I don't think it's practical. So let us not chase that 4 weeks as a cutoff. I would be rather safe in using the dose what I find, in a particular individualized case. I won't be that very rigid that in 4 weeks I have to optimize MRA, I have to optimize RNI, I have to optimize SGLT2 beta blocker. It is not possible. But with the SGLT2, it is fine. It is easy. Beta blocker to some extent is okay. And the other major problem in heart failure with the reduced ejection fraction, the starting BP only is low. You have a blood pressure of 100, 110. And now we have to use MRA. Now we have to use beta blocker. Now we have to use RNI. So that is a challenge, because potentially all these drugs will reduce the blood pressure. See, it is funny, beta blocker we are using in hypertension. But now here we are using it at a BP of 100 or 110. So don't you think it's a paradox? So we have to build up the dose over time, because by the time the left ventricular function improves, systolic blood pressure comes up, and therefore build up the dose slowly, steadily. Don't be in hurry to use just MRA 25 milligram each and every one in 4 weeks time or 2 weeks time. You can go with 12.5, half of spironolactone you can use. And RNA you can use either 50, half or quarter. Dapagliflozin or MPAR 10 milligram standard, no problem. You can use that. There is no dose building in SGLT2, standard dose. 10 milligram to begin and 10 milligram to end. Both MPA and DAPA studies are only 10 milligram. So nothing we have to build up that. Then comes a beta blocker. And beta blocker also start with very small dose, go gradually up and up like that. Maybe by the time, maybe a couple of months or so, you are able to optimize the dose. But why 1 month they are saying? Because most of the hospitalization, recurrent or re-hospitalization occurs in the first month after the hospitalization. Understand, Rajesh? This is an important thing. Because to prevent that first month re-hospitalization, they are harping on, get the medicine, that 4 weeks time. If possible, it's fine. But if it's not, I think, you can buy time.
Any role for digoxin these days? Are you still using it? Or?
Then we have to use atrial fibrillation, fast heart rate. Only thing is that now digitalization is maintenance dose is very less. We are using that particular the digitalis effect. We are using almost half of the 0.25. We are not using the earlier one. Otherwise, the digitalization oral or intravenous is there. If a patient has atrial fibrillation, fast ventricular rate, digoxin with a beta blocker is a drug. And in heart failure, when you're using beta blocker, it does have a negative inotropic effect. And digitalis is the only drug which has a positive inotropic drug. So I don't see digitalis at all will go in this situation. In fact, digitalization has shown, as prevention of recurrent hospitalization. Because this is a drug, though they are not changing the mortality. Diuretic and digitalis don't, change the mortality, but they change the, like a quality of life and the recurrent hospitalization. That's important. If you are able to buy a few months of preventing the recurrence, by that time, all these drugs will work better and better. So, you are by this time, 2-3 months time, RNI will work. Your beta blocker will work. Your SGLT2 will work. Your MRA will work. They will totally change, the neurohormonal chemistry. They are neurohormonal blockers or they are neurohormonal modulators. RNA, we call it as a modulator. They change remodeling of the ventricle. The oblong heart becomes more circular. They get, the prevention of the fibrosis. These all we have to see, The study also shows if the echo, before starting this therapy, maybe 20-25, after 3 months, it has come up to 35-40. So things like that. So there are a lot of, improvement with these drugs. Actually. Yeah. So we have to use optimization is a key. How to optimization, when to start, how to go about. This is what we have to understand in all these heart failure therapy, 3 drugs. SGLT2, don't worry about it. Not a major thing. Beta blocker, MRA, RNI. There we have to, very, very cautious in building up the dose carefully. And it is possible, according to me, if you're cautious, even outdoor clinic, not necessarily every time you have to go on doing, investigation. It's not easy for our patient every week or every 2 weeks you say creatinine and electrolyte. It's not possible, practical. Patient won't get that thing done. Common man going again to lab every now and then, and by the time report comes, patient already taken medicine. What way we are going to change the therapy like that? So we have to be a little practical, like when you are using day to day in an outpatient clinic, in our office practice, things like that. Like an anti-pro BNP, we don't do every regularly, and it is not required for the sort of, to see the response to therapy, because these all becomes, not cost effective. Okay.
Thank you, sir.
Yeah, Dhananjay, it's okay because we are nearing 9 o'clock. You have any other query or anything you want to put to the panelists? Because
no, sir. There are no many other questions, sir.
Okay.
Only one request to all panelists and now user. I request all doctors, please open your camera. So you want to take one photograph. So that's one only request I have to all panelists.
I know many times I have observed that, because I am one of the webinarologists. During COVID, I may be the maximum webinarologist in the city or in the country, I don't know the number, but I don't know how many webinars. But many times these, photos are missing, Our pictures are missing. I don't know some more are there or they not open this. Yeah.
Is Dr. Pinkesh Rajput, I request you.
Yeah.
Dr. Naren, sir. Dr. Naren Raman and Dr. Vaibhav Shirodkar, sir. If you open your camera, then it will be, yes. I think so. Rest other are busy, sir. So with your permission, sir, can you conclude, sir? Yes. Naren, sir, already there, sir.
You want me to conclude, you mean?
Yes, sir.
No, we already concluded, because I think we have given most of the points actually. Otherwise, it will be a repeat discussion. So, and
no issues, sir.
Most of the points we have covered, as you mentioned in the beginning, how to optimize indications, how to build up the dose, how to take care, when to reduce the dose, when to increase. And I think practically we had a good discussion. Okay.
So for the CIPLA side, thank you very much, Dr. Sadanand Shetty, for nicely moderation. And equally, thanks all panelists for your valuable feedbacks and your participation. Definitely, sir, already you discussed that the cost effect. So only one thing I will say that if it's single dipron, if you go, the costing is about 35 to 40 rupees. But if you go with the combination, the torsion, the costing is 25 to 30 rupees in between. Just reducing just 5 to 8 rupees. That is only I will say. And later, sir, I am from CIPLA. We really thanks to participate and give your valuable feedback, sir. Thank you very much, sir.
Thank you. See you all. Yeah. Thank you. Chal, okay. You, bye. See you.
Bye.
Bye, Dhananjay. Okay.